students, welcome back to our module on renal physiology. We start with the renal integrated system and the first topic is physiology. Okay, so starting with the clearance. What is clearance? Clearance is urinary concentration into flow rate in upon plasma concentration. Okay, so U into V is urinary concentration into flow rate. So it's almost the amount of creatinine out in the urine, because almost all of the creatinine which is produced is filtered out, is cleared. Some are secreted, some are filtered. Okay, now GFR is equal to calculate the exact GFR, we use inulin. We use the clearance of the inulin. Why? Because inulin is a substance which is freely filtered. Okay, so all of the inulin is filtered from the glomerulus. It is neither secreted into the kidney nor it is reabsorbed. Okay, so it's like most all of the inulin is cleared via filtration. So GFR is equal to clearance of the inulin. Now, renal plasma flow. So we want to check how much is the renal plasma flow, how much is flowing out, right? So we use para-aminohippuric acid. Why? Because para-aminohippuric acid in blood is equal to para-aminohippuric acid in urine. But we do not use it to calculate GFR because all of these are not filtered. Some of these are secreted into the tubules. So we just measure the para-aminohippuric acid in the urine and we can conclude, okay, that's the renal plasma flow because that is the amount equal in the blood. Then we have filtration fraction. Filtration fraction is equal to GFR upon renal plasma flow, and it's almost 20%. So this is out of total blood entering, how much is filtered, right? GFR is the filter, renal plasma flow is the flow of the blood. So out of total blood entering, how much is filtered is GFR, and it's almost 20% in the normal condition. Now we have clearance. The maximum clearance we find is of para-aminohippuric acid, which we were using to calculate the renal plasma flow. Then it is creatinine, because some of the creatinine are secreted in tubules. It's not 100% filtered. Para-aminohippuric acid is also not 100% filtered, but still 100% comes in the urine. Now inulin is freely filtered. There is inulin, there is urea, there is a little bit of excretion. Sodium only 1% is excreted, and glucose 100% is reabsorbed. So all of these three things, the last three things, urea, sodium and glucose, they are reabsorbed maximum. So their clearance is very less, because urea is little excretion, sodium only 1% excreted, and glucose is like 0% excreted, 100% is reabsorbed. So all last three reabsorbed, the first three, they are cleared in the urine, they are present in the urine. Okay, I'll repeat: para-aminohippuric acid maximum, then we have creatinine. So creatinine is the only natural thing here, right? Both pH and inulin are the artificial things which we use to calculate renal plasma flow and GFR respectively. Okay, so I repeat: para-aminohippuric acid, creatinine, inulin. So these are the ones which are actually filtered and excreted in the urine. Then we have urea, only there's a little bit of excretion. Sodium, only 1% is excreted, rest all are reabsorbed. And glucose, 100% reabsorbed, these are not excreted. So the clearance is the least of them. All right, now countercurrent. What's countercurrent? Who helps in the countercurrent mechanism basically? So countercurrent multiplier is a loop of Henle, and countercurrent exchanger is a vasa recta. So a countercurrent multiplier, the loop of Henle, is the main element which leads to the gradient formation, and which allows water to be reabsorbed. Okay, so loop of Henle allows water to be reabsorbed. We will study it later on, all of the steps which are what substances are being reabsorbed. So loop of Henle is the multiplier, M for main element, M for multiplier, and loop of Henle. Then exchanger is vasa recta. Okay, just if you look at the V shape, it looks like, okay, down and up, exchanger. So multiplier is loop of Henle and is the main element. Vasa recta is an exchanger. Now, before we get here, let's look over here, the graph. So we all know para-aminohippuric acid, it's the maximum excretion, and inulin is less. But why is the line horizontal? Because inulin is whatever is filtered in, it is in the beginning itself, and it remains same throughout because it is not secreted nor reabsorbed. So along the tube there is no change. Once through the glomerulus, all the inulin is filtered and it remains the same. throughout. Paraminopuric acid, it is filtered definitely, but some are secreted, so it increases over the time. And obviously it remains the highest because there's the maximum clearances of paraminopuric acid. Then we have bicarbonate and sodium. These are reabsorbed throughout the length of nephron, but mainly reabsorbed through PCT. So the initial decrease we see in the initial phase, then it kind of becomes constant because initially reabsorbing more, but it still is reabsorbed throughout the length of nephron. Glucose is like whatever is reabsorbed, it is reabsorbed in the PCT via SGLT2. And if you remember SGLT1, it was in the intestine. Okay, SGLT2 is in the kidney. So glucose, whatever is reabsorbed in the PCT, so it will be the graph ends very soon. It's not constant throughout. Now this is the other graph. Tubular fluid upon plasma, and again the x-axis is distance along the PT length, the length of nephron. So pH, as usual, it will be always high because it's a maximum clearance. Then we have creatinine, then we have inulin. Now you'll think, why is this not a horizontal line like in the earlier graph? So here it's not a horizontal line because overall osmolarity is increasing. Now the question comes, why is the osmolarity increasing? Because even though the initial inulin amount is same, but the water is being reabsorbed throughout the length of nephron. So since water is being reabsorbed, the concentration of the inulin increases, right? It becomes more concentrated. Even though the absolute amount of inulin remains same, but the concentration increases because the water is being reabsorbed throughout the length. So, okay. Then we have urea, because some of them was being excreted but mostly reabsorbed, but still urea. Then we have chloride, potassium, and potassium and sodium, it's horizontal almost. Then we have bicarbonate, amino acids, and glucose is the least. Bicarbonate, amino acids, and glucose are almost completely reabsorbed till end of the PCT, okay? And glucose and amino acid particularly, they are 100% reabsorbed. Glucose and amino acids are 100% reabsorbed. Okay, I'll repeat. pH, creatinine, inulin, these things we already know. Then we have urea, then you have chloride, potassium, sodium, bicarbonate, amino acids, and glucose. Amino acids and glucose are like zero, nil. Okay, now we did study counter current. Now macula densa. So macula densa is a chemosensor, and it is located at DCT, thick ascending limb of thick ascending loop of Henle. So like most of the time we hear that macula densa is in the DCT. So actually macula densa structurally marks the end of the thick ascending loop of Henle and the beginning of the DCT. So basically the macula densa ends and the DCT starts there. So it's like at the transition area between the DCT and the TAL, macula densa is located. Then we have what is the function of it? So it mediates the tubuloglomerular feedback. Okay, it responds to the tubular load of the sodium. The glomerular filtrate decreases. So what's the function of the macula densa? When the sodium load is more or high or low, the glomerular filtrate reacts basis on that. So that's the tubuloglomerular feedback. Now example, the tubule senses increased sodium. So what it will do, that's the higher osmotic load, right? It will release a secondary messenger, which is adenosine. And adenosine is a vasoconstrictor. So what it will do, it will vasoconstrict the afferent arteriole, which will further decrease the GFR. Now imagine you are a doctor and you sense that the patients have increased. You will send secondary messenger, which is adenosine, to the guard to close the door. So this entire feedback is the function of the macula densa. You sense there is increased sodium, you sense there is increased osmolarity, you send a secondary messenger, you release a secondary messenger, which is adenosine. And adenosine has a vasoconstricting effect on afferent arteriole. It will like close the door, there will be no more sodium entering, so the GFR will decrease. Now juxtaglomerular cells. So juxtaglomerular cells are modified smooth muscle cells and they are located on the afferent arteriole. What's the function? When there is a decrease in BP, it activates RAS system and renin angiotensin aldosterone system. So what does angiotensin do? The name itself suggests that it will tense, right? It will it will cause vasoconstriction, right? So if you tense the vessels, what will happen? The blood pressure will increases. So this happens when there is a BP decrease, the RAS is activated via juxtaglomerular cells, and the blood pressure increases. In RAS, one was A was angiotensin, and there is aldosterone. What's the function of aldosterone? Aldosterone increases potassium excretion, potassium and H plus excretion, and sodium and water reabsorption. So both of this will increase the BP. So macula densa is for tubuloglomerular feedback. It basically it basically responds when there is increased sodium, right? When there is increased sodium, there is an increased osmolarity, so it will cause vasoconstriction of afferent arteriole. And juxtaglomerular cells are located on afferent arteriole, and when there is a decreased BP, what will it do? It will increase the BP via RAS system. Okay, so we continue. I did some annotations. Let's get a bit little into more details. So different scenarios. You have high NaCl. So high NaCl means it indicates high GFR and high BP. How? Like, okay, so basically this happens in case of GFR. If there is a increased sodium concentration, the body is in the state to decrease the sodium, so it will increase the GFR, right? It will increase the filtration. So the response of this will be, since the GFR is increased, the BP is increased. Now let's look at the response. So how does macula densa respond? Macula densa releases adenosine. What does adenosine do? Vasoconstriction, reduces blood flow into the glomerulus by constricting the afferent arteriole, so there will be a decrease in GFR. So this is the tubuloglomerular feedback, right? Now how does JG cells respond? Now high NaCl means the BP is increased, so RAS is not activated, decrease in the systematic blood pressure, or like it doesn't act, so there's no further rise. Okay, so the combined effect is the kidney quickly balances the filtration locally while signaling the body systematically that the pressure is high. Okay, now low NaCl means low GFR, low BP. Since NaCl is low, the body in itself does not want to excrete more, so it decreases the GFR, and BP is low. Okay, makes sense. Now what does macula densa do? Because we have to maintain the GFR, all right, no matter what. So now macula densa releases prostaglandins and nitric oxide. So these are the vasodilators. So these will dilate the afferent arteriole. So there will be increase in the blood flow to the glomerulus, leading to increase in GFR. Now how does JG cell? Now renin is stimulated, RAS is stimulated, so vasoconstriction, fluid retention, all of this happens. What's the combined effect? The kidney attempts to salvage the salt and water locally while signaling the body to systematically increase the BP and volume. Okay. So what does this mean? How will it salvage, right? So it's increasing the BP and volume, like by RAS, and by macula densa it is increasing the GFR, but also aldosterone is increasing the sodium reabsorption, water reabsorption, right? So the sodium concentration, the salt concentration is also salvaged, and the GFR also normalizes. GFR normalizes by macula densa because it is increasing, it is dilating the afferent arteriole, and JG cells basically via aldosterone is reabsorbing the sodium salt. So both are normalized. Okay. Then in case of low systemic blood pressure, okay, so macula densa does not directly sense the systemic blood pressure. Its response is secondary to the low GFR, which is caused by the low BP. Okay, both are correlated together. Low GFR, low BP, high GFR, high BP. So, but JG cells sense them. Why? Because it's located where? It's located in the smooth muscle cells of the afferent arteriole, right? So it, according to the stretch, it senses if there is a low BP or is the high BP. So JG cells sense the low stretch in the afferent arteriole, and it releases renin into the bloodstream, which activates RAS. So this action causes increase in systematic BP. Looking at different steps of the renin, RAS. So renin is released by the juxtaglomerular cells. First of all, why is RAS activated? When there is a decreased BP, so renal baroreceptors, there is a less stretch. If there is a decreased NaCl delivery, So this is sensed by macular densa cells. NaCl delivery particularly is sensed by macular densa cells. What did I say about macular densa? Macular densa is basically senses low GFR or high GFR, right? So, and it does the tubuloglomerular feedback. Like depending on the increase or decrease sodium concentration, it will cause vasoconstriction or vasodilation. So it decreases it senses the concentration of the NaCl. Now, sympathetic tone is via beta 1 receptors. Then we have, okay, so according to this, RAS is, if there is increased sympathetic tone, fight flight system. So at that time, you activate the RAS. Okay, so the common question arises: why do we need increased sympathetic tone? Why do we need renin-angiotensin aldosterone system to be activated in case of fight and flight response, right? What's the benefit? So angiotensin 2, if you can see here, it acts on antidiuretic hormone, so it does not allow diuresis, right? It's anti. So at the time of FFF, you do not urinate, you don't want to urinate at that time. So it basically angiotensin 2 activates sympathetic nervous system and triggers pituitary to release ADH. Okay, also it wants us to stay hydrated. In the FFF response, we hypothalamus is stimulated, we tend to get thirsty. Also it constricts the blood vessels. So what happens is that we need to supply the blood to more organs which are more in need, right? Not to the other organs like skin or tissues or like places which are not in need. So all of that. And also beta 1 receptors are present on juxtaglomerular cells, so if there is any changes, beta 1 receptors will detect, and it will also activate RAS system. Okay, so increased sympathetic tone in case of fight and flight, RAS is activated. Okay, now so RAS is activated, what happens? Renin, juxtaglomerular cells releases renin, JG cells release renin. Angiotensinogen is released by liver and it is found in the plasma, angiotensinogen. So renin converts angiotensinogen to angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by ACE enzyme, which is produced by the liver, which is produced by the lungs. Okay, my bad. Lungs produces ACE. Okay, so angiotensinogen from the liver, from the juxtaglomerular cells we have renin. Angiotensinogen is converted to angiotensin 1. Now ACE from the lungs, angiotensin 1 converts to angiotensin 2. Then angiotensin 2 acts on adrenal cortex, it acts on the blood vessels, it causes vasoconstriction, it increases blood volume and BP. Yeah, so angiotensinogen acts on the adrenal cortex. What will adrenal cortex do? It will release aldosterone. I'll repeat again. RAS, the whole thing, angiotensin 2 is finally formed. Angiotensin 2 acts on the adrenal gland releases aldosterone. So this is how the second A part comes into the effect, right? So aldosterone is released from the adrenal cortex when angiotensin 2, when the first A acts on the adrenal cortex, and aldosterone increases sodium and water reabsorption. We are done with this thing. Yeah. So chemosensor is macular densa, which was sensing the sodium concentration and NaCl delivery, right? Now we want to check into the graph. So okay, we are checking the plasma glucose. Okay, so we do know that glucose is reabsorbed by a transporter which is in the PCT, which is SGLT2, right? So transporters are bound to get saturated, right? Like at a point it would get saturated if there is an increased glucose concentration. So beyond 200 mg per dl, the plasma glucose, the SGLT2 channels are saturated and it won't reabsorb any more glucose. So if the plasma glucose level increases more than 200, you will see the glucose in the urine. So that's what is the renal threshold. That's the renal threshold. But if you talk about the TM, the Tmax, the maximum transporting capacity of the glucose transporter, it is 375 mg per minute, which is kind of confusing. Like, how can there be two values? So it is explained by a splay phenomenon. You don't need to go into very much of details, just remember the two things. I'll still say what the splay phenomenon is. So it is basically that it tells us about the heterogeneity in receptors. Like not all of the receptors are working at a maximum efficacy, right? So even though the renal threshold level is 200 mg per dl, okay, if they ask you when you are going to see the glucose in the urine, it's after the 200 mg per dl. But Tm is 375 mg per minute. Okay, Tmax is 375 mg per minute. Now, so this is the splay phenomenon. As you see, after 200 it reaches, it start getting excreted, and it's always filtered. Most of the time it's filtered, but after 200 the renal threshold comes and you see the excretion in the urine. Otherwise you won't see. In pregnancy, physiological glycosuria is seen because there is increased GFR. During normal pregnancy, the GFR increases by as much as 50% to meet the demands of the mother and the fetus. So this results in increased volume of the blood being filtered. The renal plasma flow increases. So there is an increased load of glucose which is reaching the renal tubules. So it's obvious that the transporters will saturate and some of them will enter the urine, but it's not the problem. It's not pathological. It's a physiological condition because GFR is increasing. Now we have mean arterial blood pressure. So in brain and kidney, there is a very tight autoregulation, and major regulation is done by macular denser cells and juxtaglomerular cells, right? These regulate the blood flow even at the time of crisis. Like one of them is increasing the GFR, other one was increasing the sodium reabsorption. The macular densa was increasing the GFR, and the JG cells was increasing the sodium reabsorption by using the renin aldosterone part. So the renal blood flow remains constant from 80 to 200 mmHg mean arterial pressure. The RBF remains constant. At such wide range, the renal blood flow does not alter. Like it's a huge range, 80 to 200 mmHg, and this is why, due to the JJ cells and the macula densa. So this is the autoregulatory range from 80 to 200 mmHg mean arterial blood pressure. So even if the blood pressure increases from 80 mmHg to 200 mmHg, the renal blood flow, it remains constant. Okay. Now, cystometrography. So as the bladder fills, its radius increases. Now to keep the pressure low and prevent the rupture, the wall tension increases. You know the formula Laplace law, P is equal to 2T upon R. So when the bladder is filling, to keep the pressure low, we want the pressure to be low. So what do we do is that we increase the wall tension to accommodate the volume, like it stretches. So this is systematic. This is a high compliance. The high compliance is explained by the Laplace law. So you see the bladder, it's increasing the size. The radius is increasing, right? Radius keeps increasing. So if radius is increasing, you increase the compliance increases, the tension increases to keep the pressure normal, to prevent it from rupturing. Okay. Now this reflects the high compliance during the storage phase. That is why like we are able to store it. We are able to store the urine. You see in this, the pressure keeps increasing, but now there is a constant pressure. There is a constant pressure. Why? Due to high compliance. High compliance, it stretches. High compliance. Then after it reaches a certain level, that is 400 ml. Now there is a sensation. Now there will be a sudden rise in the pressure. In the phase 3, you will see sudden rise in pressure, and in phase 4, you will see voiding. So this is cystometrography, and this phase 2 is achieved by high compliance. The bladder pressure plateaus until a certain pressure is reached. Now moving on to GFR. Now glomerular filtration barrier is due to two things: size and charge. So anything less than 50 nanometer nm will pass, and anything more than 100 nanometer will not pass. Okay, so the range is 50 to 100. More than 100 it won't pass, less than 50 it would definitely pass. Okay, So and why is that 50 to 100 nanometer range? Because of the fenestrated capillary endothelium. The fenestrated capillary, the hole is 50 to 100 nanometer. In the fenestrated, you understand, right? There's a hole in the capillary endothelium, and that fenestration, the size is 50 to 100 nanometers. So that's the size which will allow the cells to pass. Now, basement membrane with type 4 collagen chains. The basement membrane has type 4 collagen chain. We did study in biochemistry. The basement membrane is made up of type 4 collagen. Okay. And it has heparin sulfate, which is responsible for the negative charge of the basement membrane. Okay. So glomerular basement membrane has type 4 collagen and it has negative charge. Why negative charge? Due to heparin sulfate. Now, what does negative charge would do? It would repel negative charged molecules, right? And it will attract the positive charged molecules. This explains why albumin is not filtered. Albumin is not filtered. There is no albumin in urine. Why? Because albumin is negatively charged, and heparin sulfate will repel the albumin. And what happens in minimal change diseases? There is a problem in the basement membrane, so it is no longer repelling the negative charge. Basement membrane is lost. There is no structural change, but there is no structural change. The basement membrane, the charge, negative charge is lost. Okay, there is a negative charge problem. Negative charge loss, no structural change. Okay. So there will be selective albuminuria. The albumin which was being repelled earlier by the heparin sulfate is no longer repelled. Now, the third filtration barrier of glomerulus is visceral epithelial layer. It consists of podocyte foot process. Okay, the visceral epithelial layer consists of podocyte foot process, and this is also altered in minimal change disease. The podocyte foot process is effaced. I'll repeat again. So, three things forms the glomerular filtration barrier. The first is the fenestrated capillary, which allows the size of 50 to 100 nanometer. Then is basement membrane, which is made up of type 4 collagen, and it has heparin sulfate, which gives negative charge, and it repels the albumin because it is also negative charge, and it is affected in minimal change disease. There's no structural change, but there is a problem in the charge. Now there is a visceral epithelium layer consisting of podocyte foot process that is also affected in minimal change disease. Now, NSAIDs inhibit the prostaglandins. And what did we say about prostaglandins? Who was releasing prostaglandin? The macula densa cells was releasing prostaglandin in case of low NaCl, right? In case of less blood pressure, less GFR, so prostaglandins was released to vasodilate the afferent arteriole and increase the GFR. Now, NSAIDs inhibit the prostaglandins. So what will happen? The renal blood flow will decrease, the GFR will decrease. Basically, prostaglandins function is this. The NSAIDs is inhibiting the entire thing, okay? So it will decrease all of that. The prostaglandin is increasing the renal blood flow, plasma flow, and the GFR. So there's no delta FF change. Just remember, prostaglandins dilate afferent arteriole. You don't even have to remember. You know prostaglandin does the vasodilation work. But still, PDA, prostaglandins dilates afferent arteriole. Now, efferent arteriole. So, angiotensin 2 preferentially constricts efferent arteriole. We did speak about the RAS and how it is affecting the BP, but we did not say what it is actually tensing, what it is actually constricting. So, it is constricting mainly efferent arteriole and not afferent arteriole. Okay, but the cells, the juxtaglomerular cells, which is responsible for releasing renin, is present in the afferent arteriole, but it's not acting on the afferent arteriole, it's acting on the efferent arteriole. And so so angiotensin 2 preferentially constricts. So what will ACE inhibitors do? ACE inhibitor, what was the ACE used? It is converting angiotensin 1 to angiotensin 2. So ACE inhibitors will lead to no formation of angiotensin 2. So it will decrease, and so the opposite thing will happen. How to remember? ACE, angiotensin 2 constricts efferent arteriole. I don't think so. We should be thinking whether you might think that ACE is constricting. No, angiotensin 2 is constricting. Tensin, you know the word. So it's constricting efferent arteriole. So basically, this both is important. Now, what's the net filtration pressure? First, you need to understand what is filtration. Filtration is the blood which was being filtered from the glomerulus into the tubules, right? So for filtration to happen, the hydrostatic pressure in the glomerular capillary should definitely be high. So that will be the positive part, okay? That will be the positive part, and then rest you can arrange. In the Bowman space, it will be definitely low, and it will be in the minus part. And the oncotic pressure is interchanged, okay? Because it's about the protein. Now, scenarios. Now you have afferent arterial constriction. So anytime constriction happens, one thing to know is anytime any of the blood vessels, I'm not talking about the ureter, I'm talking about the blood vessels, constriction of vessels, arterioles. Anytime constriction happens, renal plasma flow decreases. No matter what constriction is happening, there is no flow, so renal plasma flow decreases. Now, afferent arteriole is constricting, so renal plasma flow is decreasing definitely, and GFR will decrease in afferent arteriole constriction because you're constricting it. And in efferent, there is more time to get filtered. If there is efferent arterial constriction, so GFR will increase. Now, in case if both are decreasing, the filtration fraction, which is GFR upon renal plasma flow, will remain same. Efferent arterial constriction will increase, the filtration fraction will increase. It's very logical if you think. You don't have to learn everything, you just have to think everything. Now you have high plasma protein concentration. So what does high plasma protein concentration mean? Oncotic pressure, right? The oncotic pressure was actually telling about the proteins. And where? In the glomerular capillary is increased. Okay, you need to understand rather than straight away going to the pi-GC part, okay, oncotic pressure part, okay. Plasma means blood, isn't it? So in blood, you have more solute. So anytime there is more solute, you don't want to throw away water because it will become even more concentrated. So for that, you have to bring in more water or prevent water excretion. And how you will do that? By decreasing the GFR, because GFR you are actually throwing away the water or blood. So in case of high plasma protein concentration, GFR decreases, RPF remains same, there's no change in renal plasma flow, and filtration fraction decreases. Okay, now low plasma protein concentration, in blood you have less solute, so it's like basically you can say hypoosmolar, right? And water moves from hypo to hyper, so basically in the urine it is hyperosmolar, you can say. So GFR will increase, you want to throw away the water, and again RPF remains same. Now ureter constriction is basically, so ureter is constricting. Just think of a tube which is constricting, the pressure will increase, right? So the pressure will increase in the ureter or in the tubules, you can say. Definitely not in the glomerulus, in the tubules, in the later on part. So the pressure, the hydrostatic pressure in the Bowman space will increase, it will get transferred, so the GFR will decrease because you don't, already constricted, already the blood pressure is too much, so you don't want more water to come in, you don't want the more fluid to come in and increase the pressure, you want to decrease, so you will decrease the GFR. Again, the renal plasma flow doesn't change because it doesn't matter, it's very low down. Renal plasma flow is up to the afferent arteriole and efferent arteriole. So again, filtration fraction will decrease, dehydration, all of the fluid increases. Well, I don't know why did I say that. Just forget it. In case of dehydration, you don't want more water to be excreted. You're already dehydrated, right? So GFR decreases, renal plasma flow decreases very much. So filtration fraction increases. Because during dehydration, we are trying to filter more overall. We are trying to filter more. The filtration fraction increases, but overall, both GFR and renal plasma flow is decreasing. Next, okay, looking at the relative filtrability, we are talking about the charge part. We did skip this. So negative charge is repelled by basement membrane, so it's not filtered. It's like you see, it's 0.6, it's not filtered. Minimum filtration. Neutral charge, and then positive charge it will attract, so maximum filtration is there. So we did say that we will study where and which part different molecules and so are being reabsorbed, right? So, renal tubules. Now, we study about the PCT first. Okay, the first part, PCT. So, in the apical side, we have apical side is basically the urine part, and the base of the artery is blood. So, B for B, and the other side is apical, which is urine. Okay. Now, apical side, we have SGLT2 inhibitors. Sorry, my bad. We have SGLT2 receptors. Channels, you can say channels. So what was the function of SGLT2? It was reabsorbing glucose, and along with that, it's not just reabsorbing. The name itself, it says sodium glucose transporter, right? So it's both sodium and glucose, it's reabsorbing. 100% glucose, and a little bit of 1% sodium is excreted, but still, okay, most of them are reabsorbed. Now, what does SGLT2 inhibitors will do? It will obviously inhibit the channel, so there will be no reabsorption. Example is all the gliflozins, all the flozins were glyphs were the canagliflozin, empagliflozins, all the gliflozins, okay, was inhibiting SGLT2. We'll probably forget, because if you look at these drugs, who is glyphs and who is glyphs, all of that. Okay, so I got a trick. F for first, right? First part of tubule, like PCT, first part of tubule, PCT. So it's for the gliflozins, and glucose for, you'll get that. Okay, F, you might confuse that, what's that? So F for first part, so it's for gliflozins. Okay, now then if you remember, angiotensin is causing increase in BP, right? How will it cause? By reabsorption of sodium. One of the method is reabsorption of sodium, so water will follow it and it will increase BP. So it increases sodium reabsorption and it excretes the H plus. H plus combines with the bicarbonate present in the urine, and it will form H2CO3. Okay, so acetazolamide acts on okay, looking into it, what exactly acetazolamide is doing. It's inhibiting carbonic anhydrase. So let's look at it. Angiotensin 2 was increasing sodium reabsorption in exchange of H plus, right? H plus plus bicarbonate was forming carbonic acid. Now, carbonic acid in presence of carbonic anhydrase is breaking into CO2 plus H2O, which was further getting reabsorbed inside. Okay, and then it was again forming H2CO3 in presence of carbonic anhydrase, and it was further breaking down into H plus plus HCO3 minus. So basically, H plus is at the end getting excreted only. Okay, it is entering into the urine. But what is bicarbonate? What's happening with the bicarbonate? In all of this step, the bicarbonate is being reabsorbed. Now, if you're inhibiting the carbonic anhydrase, what will happen? H plus will anyways be reabsorbed, anyways be excreted, because it's the function of angiotensin 2 which is causing its excretion, right? Or you can say secretion. But if carbonic anhydrase is inhibited, the bicarbonate won't enter into the tubule and won't be reabsorbed, right? So basically, what is acetazolamide? Don't read it acetazolamide, read it as acetazolamide. H plus is in the urine, not primarily due to it, but it is in the urine, right? So that is not the primary function, is it? I'll tell you what's the primary function. Bicarbonate is not being reabsorbed. Bicarbonate is a base. If it is not being reabsorbed back into the blood, the base is not coming back into the blood, it is acidic. So the blood becomes acidic, so that's why it's known as acetazolamide. So acetazolamide is read as acetazolamide. Now, so it inhibits the reabsorption of bicarbonate base, so it leads to metabolic acidosis. Okay, so even though the H plus is excreted in the urine tends to become more alkaline, primarily because of the bicarbonate. The bicarbonate is more dominant, you can say. So even the H plus is being excreted, but the primary function is bicarbonate is not being reabsorbed. The problem is the reabsorption. So acetazolamide causes Metabolic acidosis. Why? Because bicarbonate is not reabsorbed. Okay, that was the function of, yeah, and also the chloride is being reabsorbed. We also did mention, if you remember, let's go back. Yeah, chloride, potassium, sodium, all of them were reabsorbed. So all maximum of them were reabsorbed in the PCT itself. So chloride is also reabsorbed in the PCT in exchange of base. So you see now, in case of acetazolamide, base is being excreted, plus you're not allowing the reabsorption of base. So that's how the bicarbonate is coming in the urine. You got it? And it's not being reabsorbed, unfortunately, due to acetazolamide. Otherwise, in normal conditions, due to carbonic anhydrase, it was being reabsorbed. Okay. Now, also few hormones act on PCT. Parathormone. What is the function of parathormone? Parathormone was increasing calcium reabsorption and decreasing potassium reabsorption, like increasing potassium excretion, you can say. So parathormone has two functions, but the phosphate functions particularly is over here. The calcium field function we will study in the DCT. Okay, so PPP. Okay, parathormone, phosphate, and PCT. PPP. P for PCT, P for phosphate, P for parathormone. Okay. Now, increases potassium excretion. Phosphate excretion over here. Yeah. I said a lot of time potassium. Excuse me. I meant phosphate. Phosphate. Yeah. I meant phosphate excretion. Now, angiotensin 2. We already discussed, right? Sodium water reabsorption is doing, and bicarbonate is also being reabsorbed. You see, the whole process was due to the angiotensin 2. Now, acetazolamide was just hindering the whole process of the angiotensin 2. It was causing sodium and water reabsorption and and bicarbonate reabsorption. So all of this is known as contraction alkalosis. This is known as contraction alkalosis. Because bicarbonate is being reabsorbed, also you are causing contraction, you're causing like angiotensin, right? So contraction alkalosis. Now 60% water. So this is the maximum. This is the maximum water anywhere. If they ask you where is the water absorb maximum, no matter what, it's the PCT. Because 60% water is being, the rest 40% is left. Even though any one place is reabsorbing the rest of all, still it will be less because 60% water is being reabsorbed in the PCT. And almost all glucose, bicarbonate, urea, and amino acids. So it is isotonic here. Till here, if you see the osmolality will be isotonic. Why? Because the water is being reabsorbed, a lot of water and a lot of solutes. So it's isotonic here. Now moving to the thin descending loop of Henle. Over here only there is water reabsorption. Only water reabsorption. If you remember, the main effect, which is multiplier, main element, was loop of Henle. Now we will come to know why. Because main element was doing what? It was causing leading to the gradient formation, right? Allowing water to be reabsorbed. But why is it known as a loop of Henle? Why is it known as multiplier? We'll come here. So here it is causing water absorption. So it is a concentrating segment, right? So what is it doing? Concentrating segment meaning it makes urine hypertonic. Better word would be reabsorption, right? Reabsorption. All the water is being reabsorbed back into the body. So urine is becoming hypertonic, like it's very concentrated. So it's basically descending loop of Henle, which is the thin limb. It is concentrating segment. Okay. Now we have thick ascending loop of Henle. So thick ascending limb is the ascending part. Okay. Now it is impermeable to water. So it won't be sending away any, like there'll be no reabsorption of water from this segment. So what it will do? There'll be no reabsorption, so the urine will become hypotonic because solutes are being reabsorbed, but the water is not being reabsorbed. So solutes decreases, solvent is still the same, so it becomes hypotonic urine. Now let's see what solutes are reabsorbed. So sodium, potassium and 2 chloride are reabsorbed. 3 sodium in exchange of 2 potassium. Then we have diffusion down the electrochemical gradient. Is the pump is required for the 3N and 2K, right? But the down the gradient we have potassium and chloride reabsorption. So a lot of things. So basically sodium, potassium and chloride are being reabsorbed in thick ascending loop of Henle. Sodium, potassium and chloride. Sodium, potassium and chloride are reabsorbed in thick ascending loop of Henle. Now, also magnesium and calcium are also reabsorbed, but it has no channels. It is a transcellular spread in between the cells, or you can say it's a paracellular transport. It occurs due to diffusion, which is created by the potassium channel. It is via electrochemical gradient created by the potassium. So magnesium and calcium are also being reabsorbed, but it is paracellular or transcellular transport, not due to any channels. Rest of all are channels, even though if they are going down the electrochemical gradient, it's still channeler being used. Magnesium and calcium, no channels. Now, what happens in loop diuretics if you use loop diuretics or you have a Bartter syndrome? So it inhibits the reabsorption of these things. So there will be no reabsorption of potassium, sodium, chloride. Or in Bartter syndrome also, there will be no reabsorption. There is a problem in this channels. How to remember? Bant do loot lo mote se. Mote, why did I say mote? Because it's the thick ascending loop of Henle, right? So bant do loot lo, it's like you just like a thick person has a lot of things, so you're just giving it, you are stealing it, loot lo, bant lo. So Bartter syndrome, loop diuretics acts at the same place. It inhibits the reabsorption of sodium, potassium and chloride channels. Okay. So that was it for thick ascending limb. Yeah. Now you have DCT. Now DCT, thiazide diuretics. Okay. First of all, let's see what is being reabsorbed, right? Okay, one question I'll ask you. Where is water impermeable? It is thick ascending. Where is solutes impermeable? It is thin ascending. Only water is being reabsorbed in thin and only solutes are being reabsorbed in thick. So thin is causing dilution of the urine because only water is concentration of the urine because water is being reabsorbed, only solute is left. Thick is causing dilution of the urine because water remains same, solutes are reabsorbed. NaK and Cl. Where the loop diuretics or Bartter syndrome acts. Now DCT. DCT causes reabsorption of sodium and chloride, not potassium. NaKCl was only thick ascending loop of Henle. How do we remember that? For thick, and in DCT we don't have any word for K, so potassium is not being reabsorbed, just sodium and chloride. And here as well, magnesium and calcium are being reabsorbed, but here we are using channels. In case of thick ascending loop of Henle, it was a paracellular transport. And here we have calcium reabsorption. Okay, here we have calcium reabsorption. Do not confuse NaKCl with NaKCa. It's a different thing. Cl is a different thing. Ca is a different thing. Okay, so in DCT we have calcium reabsorption via action of parathyroid hormone. Parathyroid hormone was causing potassium phosphate excretion via PPP. Calcium reabsorption via DCT. So sodium, chloride are at the one channels where thiazide diuretics act. So thiazide diuretics basically inhibits the reabsorption of sodium and chloride. No longer potassium. Potassium was for loop. Loot low, bant low, mote is thick, K for potassium, NaK and Cl. Now these channels don't function in, the sodium and the chloride channels don't function in Gittelman syndrome. There it was Bartter syndrome, here it is Gittelman syndrome. Thiazide diuretics, Gittelman syndrome. T here is very much obvious, so T for thiazide diuretics, T for Gittelman syndrome. Also it causes hypomagnesemia. So basically it is affecting this also. It also causes hypo. So along with that's a different function, all right? That's a different function. It's acting at one of the channels and sodium chloride is not being reabsorbed. It also acts on magnesium. It decreases the magnesium reabsorption. So it's causing hypomagnesemia. Okay. Now, Gittelman is for sodium chloride. Now, instead of potassium, what do we have here? Magnesium. Finally, the last part, which is collecting tubule. Now you see here chloride is the paracellular transport is happening in case of chloride here. So what's the function of collecting cells? So we have three types of cells in collecting tubule. We have principal cell, we have alpha intercalated cell, and we have beta intercalated cell. Principal cell, alpha intercalated, and beta intercalated cell. Now in principal cell there is water reabsorption, potassium excretion, and sodium reabsorption. So there is an ENaC channel here. There is an ENaC channel which causes sodium reabsorption here. Alpha intercalated cell is basically causing bicarbonate reabsorption. H plus excretion. H plus is being excreted, right? H plus is being excreted, potassium is being reabsorbed, and H plus is excreted. Don't confuse yourself that potassium is being in exchange of H plus. Just remember that H plus is being excreted. Then finally in beta intercalated cells we have chloride and bicarbonate are exchanged. What is the takeaway? Because there's a lot of things, so many things. What's the takeaway? So see, principal cells work in so ADH, which circulates in the bloodstream, binds to the V2 receptors on the basolateral membrane, the side facing the blood of the principal cell. Because ADH is circulating in the bloodstream, right? So it's acting on the basolateral side.
Mehek, WhatsApp audio.
So this causes signal transduction. So this binding, when ADH binds to V2. First of all, how do we remember V2? Remember angiotensin 2 was acting on adrenal gland. It was causing okay, that's a different thing. Sorry, my bad. That's a different thing. But yeah, angiotensin 2 was causing ADH stimulation, right? Via acting on posterior pituitary. Activates sympathetic nervous system and triggers the pituitary to release ADH. So angiotensin 2 was causing. So ADH acts on V2. Okay, a way to learn. Yeah, so where were we? Now signal transduction is happening. This binding initiates a G protein mediated signaling cascade within the cell, leads to the production of cyclic AMP and activation of protein kinase A. Okay, so now pKa, the protein kinase A, causes intracellular vesicles containing a specific type of channel known as aquaporin 2, again 2, to move and fuse with the apical membrane, which is the side facing the urine. Okay, so the aquaporin 2 moves and fuses with the apical membrane. So this causes the increased number of aquaporin 2 channel makes the apical membrane highly permeable to water. So it causes water reabsorption. It prevents the diuresis. ADH prevents the diuresis. It causes reabsorption, highly permeable to water. Okay, so now aquaporin 2 is making it highly permeable. Driven by the osmotic gradient, the filtrated and the hypertonic renal interstitium, water moves out of the tubal lumen through the principal cell and existing aquaporin 3 and 4 on the basolateral side and back into the bloodstream. So like there are a few aquaporin channels invested here in the principal cell. Okay, so that was the function of ADH. It's acting on V2 receptor activating the aquaporin channels. They are acting on the apical side, increasing the permeability of this water, causing water reabsorption. Okay. Now, few things to remember is that aldosterone causes potassium and sodium excretion. Potassium and sodium excretion. And sodium and water reabsorption. So, potassium is excreted from the principal cell and H plus is excreted from the alpha intercalated cell. How do we remember? Acid for alpha. Alpha, acid. So alpha cell causes acid excretion. Alpha, right? Alpha acid H plus excretion is from the alpha intercalated cell and the potassium excretion is from the principal cells. Okay. So different places it acts. It causes potassium excretion and water excretion. H plus excretion causes reabsorption of the sodium and water. Now, one thing to remember, there's a trick. Just remember alkalosis. What does alkalosis means? H plus is decreased and K here means K plus is also decreased. Both K plus and H plus go together except for the acetazolamide place. Rest all places K plus and H plus are like, if they increase together. If they decrease together. The only difference is in case of acetazolamide, we'll see in more later on. This also happens. This also is in RTA type 4. In RTA type 4, we have hypoaldosteronism. We have K plus and H plus is increased. The problem in RTA type 4, K plus and H plus is not being excreted. They increase. It causes hyperkalemia and it causes acidosis, the opposite of alkalosis, right? Now, Liddle syndrome. Remember the ENaC channels? Yeah. So, ENaC channel was causing sodium reabsorption in the principal cell. In Liddle syndrome, what happens is, there is an autonomous activation of ENaC channels. What will happen then? In case of, this is hyperaldosteronism case. Okay, so you know aldosterone is causing sodium and water reabsorption. What happens in hyperaldosteronism is the autonomous activation of ENaC channel. So too much sodium is being reabsorbed. It causes too much sodium to be reabsorbed due to autonomous. This is also known as Liddle syndrome. So we studied 3 syndromes. First one was Bardo-Luetlo mote se, like Na plus K plus Cl is being not being reabsorbed. They are excreted. Then we have Gitelman syndrome T for thiazide. So in this, sodium and chloride, no potassium here. And instead of that, we have magnesium. So these are not being reabsorbed. These are being excreted in the urine, decreased in the blood. Liddle syndrome, we have hyperaldosteronism, autonomous activation of the sodium channels, ENaC. Now, amiloride and triametrine are potassium sparing diuretics. So if they are potassium sparing diuretics, so it will not allow the excretion of potassium, right? And along with potassium, we have H plus bonus. So it only acts on ENaC channels and it causes sodium excretion. So basically the opposite function of the aldosterone. Sodium excretion, then water excretion will be there, but K plus and H plus are increasing. It is a potassium sparing diuretic. Amiloride and triametrine. Then, so there is a hyperaldosteronism in Liddle syndrome. We saw the ENaC channels being hyperactivated, autonomously activated. Hypoaldosteronism, opposite the effect, is RTF type 4. We were seeing hyperkalemia acidosis. Now, 1 to 2% water will be absorbed if there is no ADH. In case there is no ADH, the water, there will be diuresis. Only 1 to 2% water will be reabsorbed from the collecting duct. But if ADH comes into play, 10% water reabsorption takes place in the collecting duct. Despite ADH, the maximum water reabsorption is in the PCT, as we said earlier, because PCT is 60% water reabsorption. No matter what ADH is there or not there, 60% water will be reabsorbed from the PCT itself. There is a bonus 10% if we have ADH, and if there is no ADH, there is only 1 to 2%. Okay. Now coming to the pharmacology, we are done with the physiology. Now, acetazolamide, how we'll pronounce it as acetazolamide, right? So I think we should do diuretics in the next video. I think next video we will continue.